Hi, everybody. Welcome to UIC's webinar for today, which is Post-Pandemic Reconstruction and Transition for Experiential Learning. Thanks, everyone, for joining us today. As you were signing on, we had a poll because we wanted to know what kind of simulation programs or education programs were you working in. And we're going to go ahead and share those results with you now. So it looks like, by and large, most people were school or university based at about 75%. There were about 15% that are hospital based. A couple that were standalone from nonprofit organizations, from a government or VA, and other. So thanks everybody for joining us, and we hope to have a vigorous discussion today. So I'd like to begin with some introductions. My name is Christine Park. I'm the director of the Simulation and Integrative Learning Institute here at UIC in Chicago. And we are delighted to welcome a guest speaker from the University of Iowa. So Jane, would you go ahead and introduce yourself, and then Bob, please.
Sure. Thank you, Christine. I'm Jane Lindsay Miller. I'm the director of the Office of Consultation and Research in Medical Education, and also a clinical associate professor in the Department of Family Medicine at the University of Iowa. And I'm delighted to be here today and talk a little bit about what I've learned about disaster response and recovery and how it applies to education, especially experiential education and simulation.
Hi, everybody. My name is Bob Kaiser. I am the Associate Director of the Simulation and Integrative Learning Institute, and I am so excited about this presentation. It's been so fun to prepare this, so you're in for a treat.
All right, great. So I wanted to open with a little reflection, which is, at least for me, I think I've felt a lot of times that I've been spinning my wheels, spending a lot of effort for making decisions that that have to be changed at the last second. And maybe, you know, some of us have had the feeling that we're a little bit wasting our time or being redundant with our time. And I wanted to share this quote that I found from The Little Prince, which was just, which really encapsulate, I think, what we're all doing with our efforts and our passion for education and for simulation. So it's not time that we are wasting after all. It's the time that we are quote unquote wasting that itself makes all our efforts so important. So we're going to open with that reflection. The next thing I want to call all of our attention to is to think about, as we're preparing and thinking about a new normal and going on to the next phase of disaster management, to think about elements from the simulationist code of ethics that may be helpful. I think that a lot of times we think about the code of ethics as being relevant to our learners, and it surely is. But there's also a lot of stuff that we can think about in terms of maximizing safety and minimizing physical and psychological risk for ourselves as educators and our staff. Think about the resources that we have, and also think very deeply about what are the potential unintended consequences of the decisions that we make. Sharing also this, this hierarchy of controls, which is put out by the National Institute for Occupational Safety and Health. And the thing that was really, that really caught my attention when I saw this is that the notion of PPE or, you know, cavi wipes and those things are really ultimately the last stopgap in terms of creating safety for workers. And so for me, I'm a clinical anesthesiologist. I kind of have to do this. There is no way for me to completely eliminate the hazard, which would be the best intervention. And I think for us thinking about going forward, we're going to need to be somewhere between just relying on PPE, and there's no way that we can continue to completely eliminate any hazard. So throughout today, we're going to explore some of how we're going to exist in the in-between. So when thinking about clinical education, there's the FAA actually has some really interesting thoughts about this. Level 1 education is the novice level, where we're learning to just perceive information and cues. Level 2, we're a little better now. We can comprehend the situation. We can put together the data in a way that makes sense. And finally, level 3 is our ability to use that data and online learning to forecast and to plan for future events and dynamics. And if you think about what we're up to in terms of planning for the evolution of this pandemic, we are all trying to get to this level 3 place and to get out of the place of just action reaction loop. So I thought that this was something that would be relevant to frame how we're going to approach today, but we're going to very shortly hear something really cool. Before we do, let's have a quick poll.
Okay.
So this is two questions. One is, my unit is well prepared to address educational challenges as the COVID-19 pandemic continues to evolve. Anywhere from strongly disagree to strongly agree. And question number 2 is, I feel well prepared to address educational challenges as the COVID-19 pandemic continues to evolve. Again, strongly disagree to strongly agree, or I don't know and or unsure. So go ahead and type in your responses there. And we'll go ahead and give just 10 more seconds here or so. Great. All right. I'm going to go ahead and end the poll. So it looks like in terms of my unit being well prepared, the vote is about evenly split between disagree and agree at about 35-ish% each. Strongly disagree and strongly agree are also coming in at about 6 to 7% each. And about 17% of you say that you don't know or you're unsure. As for whether I feel well prepared to address the challenges, about 43% of people said agree, 30% said disagree. About 10% of you said I strongly disagree, that I am well prepared. There's a few people, 3%, who said strongly agree, and again, about 15% that said I don't know or unsure. So we actually did share this poll on SurveyMonkey in advance of the webinar, and the results were somewhat similar for the my unit is well prepared, but for I feel well prepared, at least for this cohort of people, there are many more people that said that they personally didn't feel that they were well prepared. So with that, I am going to turn it over to Jane.
Great.
Jane, have the floor.
Thank you, Christine. So first of all, let me talk a little bit about how I came to this subject, and I think what I might be able to offer in this conversation. About a decade ago, I was fortunate enough to be the principal investigator on a CDC-funded project to develop, validate, and implement a simulation curriculum on disaster response that was designed specifically for health science students. And that experience introduced me to the whole world of public health scholars and practitioners who devote their whole career to studying disaster response and recovery. And as a result of that engagement, I also attained training in the National Incident Command Structure and have also received some credentials in that, and have really benefited from that experience in my subsequent work on the practice of teaming and responding to emergent crises. So when COVID-19 started to really change our daily lives, both personally and professionally, I immediately thought about how that training and experience might relate to the challenges we're facing, excuse me, as educators. I really thought about the ambiguity, the sense of unpredictability that some of you may be experiencing as well, and the polling results seem to indicate that. So, you know, definitely a portion feel very secure about your ability to meet emerging or changing needs, while a significant proportion still do not. And it really forces us into a position sometimes where we may think we have no choice, or we can only react to what's happening in a very short-term kind of context. However, what my experience in training has taught me is that there are models that we can rely on to help us find a different way to empower ourselves to think beyond immediate reaction and hopefully prevent decisions that preclude us from making better choices at a later phase in the disaster recovery cycle. So we're going to unpack this resilience model. And by the way, this is a very typical characterization of a disaster response and recovery cycle. And we're going to unpack this term of resilience and how it also applies to the experience in a disaster recovery. It is a little, system resilience is not the same as when we talk about resilience in terms of personal well-being. System resilience, for the purposes of this conversation, is really about the ability of critical systems and infrastructure to maintain functions, processes, or populations after experiencing disruption. So the kind of resilience we're talking about in this model is the ability of our systems to take stress. And that system can include our educational systems. How at a systems level are we able to continue to respond as this crisis continues? Let's take a look also at some things that we do know. We do know COVID-19 outbreaks are likely to persist for 12 to 24 months in the US. We know that the impacts on population health and the viability of healthcare systems will persist and continue to be global. And we know that our learners will continue to need experiential education, both clinical and simulation education, as all of this unfolds. So we know that the American experience of the pandemic, at the very least, is unlikely to be V-shaped. In other words, it's unlikely that we'll have the pandemic and then bounce. We already see that happening. At its worst, it's probably more likely to be a W shape, where we vary in terms of, but stay sort of at the bottom in terms of our capabilities, or at best, kind of more like a Nike swoosh, where we're having a more gradual ascent in our system's abilities to adapt. But at base, we do know that the epidemic is not over. No epidemic is over until you have at least 70% of a population achieving immunity, either through exposure or through vaccination. And given the circumstances, best estimates are still that we may need to be higher than that in the United States. The reemergence, just today being reported, of the virus in South Korea and Germany is probably a really good indication of what we're looking at in terms of what we need to continue to respond to, as both individually as educators and with in our systems as a whole. So let's go back to the disaster response and recovery cycle and think about this, how this applies more specifically to our recent and prospective experience as educators. So when you are here, let's start with the response portion. Planning is extremely short term. What's going to happen tomorrow? What's going to happen next week? Resources are limited to what is immediately available, and any kind of guidance from other organizations or titular leaders is limited or non-existent, because everybody's in the same, basically in the same situation. And goals are about meeting immediate needs. If you feel like that describes where you were in March, or even very recently in April, that's where you were placed in that disaster and response recovery cycle. So the questions are really, how are we going to safely teach students tomorrow? And that means in both a clinical and a simulation context. As we move to phase one, which may feel a little bit more like where you are now or where you have just been, planning is short term, but it's no longer, it's a little bit longer than in response. Resources are expanding, guidance is limited but improving, and goals start to include some deferred needs from the response mode. So for example, it may be more of a question, how will we continue to safely teach students? We feel like we've got some mechanisms in place, but how are we going to continue those? And how can we start to add or augment to that? So think about that and what some of the implications are for where you are right now, or where you've been, the kinds of conversations you may have had most recently. As we move into phase 2, you start to see something that looks a little bit more like reconstruction. And part of the reason I bring this up is a critical component of this disaster response and recovery cycle is the assumption that recovery is never identical to what existed prior to the disaster itself. This is a really, really important concept. In both our systems planning and our psychological orientation to this, I think it's really important to make the assumption and to even state it very explicitly that whatever we're reconstructing toward, it's not going to look exactly like it did prior to COVID-19. So this is the point at which in recovery and reconstruction, you can start to see planning timelines that become more diverse. You have both short-term and longer-term sorts of timelines. Resources are being shared more, so having conversations just like this one is actually a critical component of that. And guidance is starting to consolidate some of those innovations and adaptations. This is something where we'll probably start seeing some of the things that we're innovating or incorporating into our practices start to become part of the expectations for what we're doing. And goals are starting to consider long-term needs. So where I would sort of benchmark this in terms of timeline is what we're moving into in June and beyond. We don't know how long that phase will continue to be. We don't know how much we're going to toggle between different phases. Again, it's in relationship to that, the evolution of the COVID-19 pandemic. So you start to ask questions like, how will we incorporate new teaching expectations into new teaching practices into ongoing expectations, both for clinical practice and for simulation. And then finally, we can start to talk about how we move into phase 3. This is the point at which stakeholders start to ask questions about damage assessment. Really looking back and thinking about what are the kinds of sacrifices, if you will, that we've had to make in order to get by, and what has the cost been? So how do we remediate that, or how do we address what some of the issues have been associated with that? Resources actually may start to become constrained again, in part because of that damage assessment. If you're talking about remediating what has been some of the cost associated with the previous phases and meeting immediate needs, you may see resource constraint all over again. Guidance consolidates and expectations become clarified, and goals are directed more toward stabilization in phase 3. And I think we can assume that at some point in 2020 and probably well into 2021, that's where we're going to start to see some of that transition phase into business as usual, but a new normal. And a new normal that will not be exactly like the normal that preceded COVID-19. So we'll see that we start to ask questions like, how will we stabilize systems and incorporate new needs into that business as usual? So some of the things that may have seemed like a temporary short-term or even medium-term adaptation now become critical resources that are more like utilities than add-ons. So we have to think and plan for that very carefully. Okay, time to go to the polls.
All right. So we'd like to know, where do you think you are in the disaster cycle? Are you in business as usual or new normal? In the immediate post-disaster response phase? In phase 1, which is that first phase of post-impact relief? Phase 2 into recovery and reconstruction, or as far along as phase 3, which is a transition back to a new normal? Again, business as usual, immediate response, phase 1, phase 2, or phase 3. We'll give just about 10 more seconds here. Okay, I'm gonna go ahead and end the poll. And it looks like by and large, most of us, just over 40%, are in that phase 1 post-impact relief. I would say that that's where we were as well. About 25% say that they're in the immediate post-disaster phase, and also about 25% in the recovery and reconstruction phase. One person said that they were in the business as usual, and a few people felt that they were in the phase 3 of transition. Great, so thank you for that. Thank you for sharing. All right, Jane, back to you.
Yeah, so another tool that I learned and have been teaching is actually a model called Coaster. This was created by Dr. John Hick, who is, many of you, those of you who are in the emergency medicine world definitely know. He's a physician and program director at the Department of Emergency Medicine at Hennepin County Medical Center in Minneapolis, and a faculty member at University of Minnesota Medical School. And John is somebody I worked with a lot on the project I was involved with, and created this model to help efficiently someone who is responding to a disaster think about what are the elements that we need in order to address a disaster as it evolves and address our response as it evolves over time. I thought this was actually a really interesting way of thinking about educationally how we would do this. Now, of course, John created this and introduced it specifically for clinical practice and team coordination, but it seemed to represent the kinds of elements that we really need in an educational response. And so that's part of what I've done, as well as adapted each of these, the 4 C's, the 4 S's, and the 4 TR's to educational issues. And we're going to go through, we're going to drill down on these and talk about examples from the CO, the S, and the TR as a way of demonstrating how you might apply this in a context, thinking about that bigger disaster recovery cycle. So this is just one, again, one tool, one model for unpacking what are the different elements that I need in order to be effective and in order to be planful in a response to recovery.
Great. So we are now going to spend the next little bit drilling down a little bit into the use of this model and thinking about it in the context of various phases of the disaster cycle. So we're going to drill down here into the CO column. We're going to look at communication, and specifically we're going to think about how to handle messaging for key stakeholders. And to do this, we're going to share with you a quick case study, which is a completely fictional letter sent by an educational leader to students. And then we're going to ask for your reactions in the chat box. If there's anyone on the phone, I'm going to read this out loud. So the letter says, "Dear students, we hope that you've been able to take care of yourselves during this difficult time, as well as maintain your study plans. Licensing exams will be happening sooner than you might think, and pandemic or not, performance in these exams will impact your career. Coursework continues to be done online. We're all doing the best we can, but keep in mind that courses may be modified without notice. For seniors, we do understand the importance of your achievements, and we're committed to conducting an in-person graduation ceremony." So please type this in the chat box. What would you take away from this if you were a learner receiving this letter?
Thanks, Shannon. I noticed that Erin said more questions.
Yep. Laura is noticing a little mixed messaging here. Take care, but it's still business as usual.
Yeah. Samantha said anxiety provoking.
It sounds a little threatening. Oh, and sensitivity to disparity of impacts. Yeah. Lou mentions sort of a dual fear as well as excitement. And
Yeah.
someone says, you're on your own. Yeah. I feel like all of this is at play. Let's move forward. Jane, what are some of your reactions to a letter like this? And how might we give some advice to somebody to think about their messaging?
So I think some of the challenges that are really typical in messaging around, in times contexts like this, are that leaders don't necessarily, or authors in this situation, don't necessarily think about the implications of what they're communicating. As everybody's already pointed out, it's actually sending this mixed message. It might be true, but it may not be precipitating the kind of response from this key stakeholder group that you want as an educator who's trying to be honest with your students. So one of the other things that I think is important is that as communicators, we need to be realistic given the phase that we're in. So the other thing is that sometimes communicators will promise something that they cannot deliver on, or that is unrealistic given the likely way in which a disaster will continue to evolve, or an educational crisis will continue, or the implications for education and the way the crisis will evolve. The other thing is that by not offering any sort of future orientation, sometimes the communications can also get stuck in that action-reaction loop, so that the communication can be too short-term. So these are all sort of, and not very helpful in helping our learners plan as they go forward. So apologies, there is a lifeline helicopter going over my office right at the moment. So you may be hearing the helicopter right now. So anyway, those are things that people need to think about in their communications. Are you sending mixed messages? Are you being clear about what you want your stakeholders, in this case, the students, to do as a result of that? And are you being clear about and realistic about what they can expect and you can expect to deliver as you go forward?
Great. Thank you, Jane. So let's move on to the next case study and the next drill down. So we're going to now look at the S column. The S column is about staff. And in particular, we're going to drop in on a conversation between a couple of people that has to do with staff orientation, mentoring, and monitoring. All right, have a look. Bob, we're not hearing the.
Hey, Laura, real quick thing. So I was just talking to IT, and they mentioned how they've been having a lot of requests from you on setting up breakout rooms and running the breakout rooms during your projects. And I believe during the coordinators meeting, we talked about actually the coordinators doing that. So I really would like for you to dive into Zoom and breakout rooms and learn how to do this.
Oh, I mean, I guess I just interpreted the meeting as like we had to use it. And so I figured I would ask IT because IT is IT and that's a computer thing and isn't that their job?
Well,
I mean, because if you want me to learn how to do it, then that's going to take like a lot of my time to figure out how to do something that we're probably not even going to use in the next, like, I don't know, however many weeks. I mean, it's not like we're going to be doing this forever. And then just to spend all of that time, it just seems kind of pointless to me.
Well, actually,
I feel like I've put a lot on the back burner already, and then to have to learn how to do breakout rooms when it's like somebody's job and IT just can't they figure it out and tell me, or I don't know. And like the other thing that like I didn't want to say in the meeting is like, are we really going to ask students to do more of this? I just feel like number one, they don't buy into it. I feel like the whole telesim thing just isn't working. And B, number two, I feel like everybody has Zoom fatigue right now. I mean, I know I do. I was on it from like 8 to 5:30 the other day. The last thing I want to do is more like Zoom that maybe if we just waited a little bit, we could get back to normal and do it for real, you know?
Awesome.
Okay. So, having watched that video, we have, we'd like to hear from you. We missed a slide here, so let's have a discussion here. What are you getting from the staff, and how might you respond?
So they have that conversation daily.
Frustration, yeah.
Yes. Staff is not getting the big picture.
Yeah, I hear that. Confusion about roles and frustration around the staff.
Lack of communication to know a possible timeline of events.
Yeah, it's possible this person might be feeling like they're being set up for failure.
Yeah.
At the same time, seems like they might be resistant to change. All right, so Jane, back at you. What would some advice be that you have for understanding and connecting with a person like this?
I think it's really interesting to see a lot of the comments coming through about that sound more like, you know, empathy building. Stand in that staff member's shoes and think about where they are, or think about having how to bring people along. Again, it's about I think communicating expectations. And we have a tendency, all of us have a tendency to feel like we should be further along than we probably are. And especially in situations like this, it does require people to be working a little bit and sometimes a lot outside of their typical scope. So building a sense of collaboration and a sense of kind of commonality is really critical. But I would also say the other thing is that sometimes it does require a little bit of assertion and a reminder to people, going back to the and the communication piece, that what we might be headed toward is not going back to the way things were before. And if we can accept that as leaders, as well as be communicating that to our staff, I think that's a critical point as well. But Bob, when we were talking about this, you had some great observations as well that I think are really relevant to this kind of scenario.
Yeah, as I keep hearing you speak, Jane, it's about the setting the expectations. And I think that sometimes as leaders, we don't always voice the expectations or maybe help shape those expectations, because expectations can be premeditated resentments. So depending on what that expectation is, if it's not following what people are expecting, you know, then they can get thrown, get upset, frustrated, and the like.
Absolutely.
Okay. And next, we're going to go to the final category, the TR category, which is educational treatment. And specifically within that category, we're going to talk about considering next step for learners. And we did have some questions in the SurveyMonkey that we put out that specifically wanted to hear us grapple with this a little bit. So one person is in a small in situ program with a huge problem of too many learners and too little time for the kind of throughput that has been that has been customary. So we actually have a case study to share with you, and whereas the first two examples were fictional, this one is real. And this has to do with the transition to clerkship course here at UIC. So in the old days, which was 2 months ago, this course was 2 weeks long, 10 full days. There were 12 skills taught in the simulation. Group sizes could be upwards of 25 people, including the learners and the instructors, all together in a big skills room. And performance was assessed. This was part of the graduation competency exam. This year, this course is going to look very, very different. It's just 3 days long. That includes didactic and simulation. The simulation skills has only 2 skills. That's PPE, donning, doffing, and a patient emergency care simulation, and BLS. Total group sizes are less than 10. That means about 6 learners per group, as opposed to something like 20 learners per group. That has changed our throughput, everything, scheduling. And then another thing is that it's unknown how or whether we can assess performance in this new approach. And so a question that we have for you, please put it in the discussion chat box, is what do you see as the pros and cons of this very modified approach?
Mm-hmm. So targeting outcomes more clearly is a pro. Mm-hmm. But we have to be thinking, what could students be missing?
So it looks like I saw a couple different comments about assessment. That one is that we do need to assess. Another person said that we can deal with that later. That was interesting.
That's a great example of deferral, something that potentially gets deferred, that gets marked and noted so that it doesn't disappear, but gets deferred for the future.
All right, Jane, so I'm going to toss it back to you again. What advice do you have to offer in thinking about preparing learners for what's coming next?
I think, and some of the comments really emphasize this, that it's important to just not build castles on the sand. Again, not be promising to learners that they're going to have exactly the same kind of experience going forward, and that the educational treatment in this case is going to change somewhat. And I love some of the comments that are coming through about thinking more intentionally, what is it that we're teaching? And what is it that we're actually using this time for, so that we're communicating that more clearly, while we also think about the kinds of things that, again, can be deferred or might be able to be taught in a different sort of context or in a different situation. I'll give you one personal example, and I don't think we've even talked about this yet, but in consulting with some of my colleagues in one particular department, they've really wrestled, how do we teach the gestalt of the patient experience? And actually, one of the things I've been talking with them about is maybe we can learn that gestalt from other resources. Maybe that's actually as an alternative. I'm not saying it's exactly the same, but as an alternative, literature, film, other sorts of ways of teaching using different sorts of tools and approaches. Some of the pieces that might be missing in more of a skills-oriented sort of teaching experience. So there are lots of ways of thinking about what is that educational treatment, how do we staff it, right? What are the resources we need to make that happen? And how do we communicate about that?
Yeah, Laura Gonzalez has asked a really good question is, what is the risk of deferring too much? And how do we make decisions around what's the need to know versus nice to know? And that's something that we did very much grapple with. Yeah, for sure. Jane, I think you were going to say something.
Oh, I was just going to say, I think this is where that's, again, a great example of where knowing what a disaster response and recovery cycle looks like helps you to kind of benchmark, okay, when can we talk about how we actually, plug that in, and at what point will it happen? Because the last thing we all want to do, we know that, is graduate people who either they don't feel prepared or we aren't confident that they're prepared to actually meet ongoing clinical and educational needs. So it is about maybe using that cycle as a way of thinking planfully about what gets deferred and to what point, so it doesn't get forgotten.
Great. And now let's go to the polls for a final poll. And the question is, how close to old normal do you predict the new normal will be? So the choices are pretty much right on the bullseye, basically the same, reasonably close, maybe a few changes to accommodate, or fairly different. We do anticipate significant changes, or very even unrecognizably different. So please go ahead and key in your votes.
Fairly different. It's coming up at winner. Mm-hmm.
All right, great. Just about a few more seconds for those last few votes here. Okay. So the results are in. We have 75% of people who feel that it's going to be fairly different with significant changes. About 10% said it may be even unrecognizably different. About 17% said reasonably close, and one person did say it's pretty much going to be right on the bullseye. And maybe whoever you are, if you'd be willing to put something in the chat box, we'd love to hear about that.
Yeah. Great. I definitely want to hear from that one person. So I know we're coming to the end of our time, and I have a question for you, Jane, and for you, Christine. So Jane, here in Illinois, our stay-at-home, it looks like maybe lifted on June 1st. Mm-hmm. So with this impending reality, I mean, for all of us here, what is one thing that you'll be thinking about?
Or would be thinking about it. Yeah, we never had a stay-at-home order here in Iowa. so that actually creates a really interesting point, actually, that so many people in our audience right now are in very different sorts of circumstances in relationship to things like stay-at-home orders, or restricting face-to-face education, or in their clinical experiences with COVID-19. So that's actually one of the things that I think makes the answer to that question challenging. But to answer that question specifically, I think it's definitely about mitigating risk. So it's being very mindful about how we actually mitigate risk, because it's not only going to be how do we open our simulation center, I think, which is an important question, but it's going to be how are we going to open our simulation center when we very likely will have to close it again and open it up and close it again and open it up and close it again. So it's thinking about this bigger context and mitigating risk within that bigger context of how we respond to the ongoing and emerging experiential education needs of our learners.
Great. Christine, what are your thoughts?
Well, I think for this, I am finding myself relying on the most fundamental thing that I learned in my clinical training, which is that every decision is a risk-benefit decision, and really not just a benefit decision, or a phenomenon called frequency gambling, which is I think it's probably not likely that it's going to happen, so let's just go ahead. And so what this means for me is to think about essential staff. And for that, I want to make a distinction between essential as a value proposition, like you're so important, versus essential from a labor perspective, which are two different things. So that's going to be a really difficult thing for us to continue to navigate. And I think it's going to be maybe a week-to-week reconsideration. We are not electing to bring our SPs back into center. All of our even physical exam is being conducted virtually over Zoom. And that is a decision which we're very excited that we have good alignment with our faculty and other stakeholders. But eventually that's going to need to happen. Where, when, and how, I think I'm a little bit in the camp of it might be unrecognizably different. So that's something that weighs on my mind pretty much all the time. Thanks.
Yeah, thank you. Great.
All right, so we now would love to hear questions from you, comments, and things that you have to share. And I think we had some in the question box already. Yeah, so Laura Gonzalez asked, when applying the resilience model to a disaster that can fluctuate as COVID can and will, could or will, can you ever move back into a previous phase? And how do you plan for that?
Yeah, great question. I think it's more an issue of remaining in between phases sometimes, and kind of wiggling between those different phases as something continues to evolve. So, a disaster looks very different if it's a tornado or an earthquake versus a disaster that is an infectious disease. So the infectious disease disaster will have much longer periods depending on the nature of that infectious disease, but in stages and phases. So in this case, thinking ahead about the gold standard being immunity, that's really what's going to determine when it's at an end. Accepting the fact as well that the end will also have a number of sequelae because of all that preceded it. So yes, I think what can be useful about that, about the recovery cycle, is thinking about, okay, when I move back, when resources maybe become constrained, for instance, what do I need to think about in terms of what that might look like? So it is certainly something where the experience can be more fluid, but I think it tends to be that a population or a group will kind of get stuck wiggling in between two different phases.
So Jane, so Christian Lair had a question, which I actually do too, so that's why I'm kind of pushing it forward, is what's your advice on planning to anticipate that open-close cycle that you mentioned?
Yeah, and I can speak from experience here. We're just like everybody else. I would say that we're sort of in that phase one, with maybe a little wiggling into phase two periodically, and I think that's a big question all of us are trying to ask. How can we do that? How can we prepare for not just the reopening, but the opening and closing, opening and closing, opening and closing? And I think it's about putting in place, again, thinking about some things that looked like innovations before now as utilities, being able to go back to and rely on things like Zoom or Microsoft Teams or WebEx or whatever video conferencing tool you were talking about, as a stable, consistent kind of backbone to what we're doing, and then thinking about how that face-to-face work, like having smaller groups that meet more infrequently, becomes the addition rather than the norm. So it's about kind of rebalancing the way in which we think about the tools we use for education.
Great.
Noreen Kern has asked a question about specific recommendations provided by the CDC regarding the safety of returning students. And then related to that, Linda Freund has asked, are we bringing in SPs into center in the near future? And for that, I think I'm gonna toss it to Jane, and I'm gonna bring us back to what Jane said, which is until 70% of the population, or maybe even higher in the US, has immunity, whether by having gotten the disease or through a vaccine, there really isn't, we can't really call it safe. The best that we can do is to try to put some stopgaps. And for me, the decision is, if I decide to implement that stopgap and somebody gets sick because of this exposure, will I say that that was worth it? And until my answer is more on the yes side than it is on the no side, we have been very reluctant to proceed. So, but Jane and Bob, please weigh in on this.
Oh, and I also want to, I want to acknowledge there aren't any, as far as I know, any specific recommendations from the CDC about returning to face-to-face classes or face-to-face instruction or lab use. And I also want to acknowledge James Hawkland's point that FEMA has this great online study website on incident command. And I totally agree that that's something that people should think about, the Emergency Management Institute, as a way of expanding your toolkit in thinking about a systems approach to emergency management. So it isn't only about what's right in front of you that your dean is insisting you do or think about, or what your institution may be setting in front of you, but also thinking about this kind of bigger picture of how will we get out of the reaction mode and help you and your colleagues plan for more of a comprehensive and longer term recovery in order to build systems resilience.
And Jane, I just want to pop in here because as I'm listening, I'm applying it to, of course, our center. I think as someone who's been in the middle of this, it's really easy to say, you know what, let's just try to go back to what we were doing. Let's just go back to the old normal, because that's what we know. And it takes more energy to take that pause and to say, no, what does the new normal look like? How can we keep our staff, our SPs safe while continuing the great education? So I think that reaction is also a reaction inside of me, wanting to shut down and wanting to just go back to what I know. So thank you for that. Yeah.
Yeah. And safe, I think it's important. I want to emphasize what Christine said as well. It's not safe, it's safer. So what we're shooting for at this point is safer. And that's what we have to think about in terms of whatever decisions that we're making about continuing to incorporate as we move through phase 2 and into transition, starting to incorporate different aspects of face-to-face engagement. It's about safer, not safe.
Great. Thank you.
Bob, I have a quick question for you, which is, what are your thoughts about potentially bringing staff back to work who might be above 55 or 60 years old, or somebody with illnesses?
Yeah, so at this point, I would be very, very, very reluctant with another very in there. I think that going back to what Jane was saying, until that 70%, when we hit the 70%, I would always be nervous about any of those people returning to the center. And I love the idea of thinking of new ways to incorporate them. Right now, Zoom seems to be working, so I would want to keep those SPs active with Zoom. Also, maybe we go down from standardized encounters to simulated, where we have younger people portraying those cases, depending on the assessment needs, et cetera. So, yeah.
Okay, great. Jane, here's a tough one.
Yeah.
How might a place plan for liability?
Oh boy. I think that's a great question. I think you have to talk with your risk management people. Because that's not really, that one is sort of beyond my ken. But I think it goes back to, again, something you shared with us early on, Christine, which is about some of the ethics associated with this. So, and sharing those, using those as a way of engaging other decision makers and stakeholders about what decisions to make them, when to open, when to close, and set some guidelines and parameters that are going to be reasonable for everybody involved. But that, yeah, boy, that question of liability is really a good one. Oh, I see this OSHA guidance on preparing workplaces. Excellent.
Mm-hmm.
Excellent resource. Thank you for sharing that.
So I think we have time for one more question. And Lou Clark asked, what is one specific thing each of us is doing this week in relation to considerations for moving forward?
Great question.
Oh, consideration for in terms of going forward.
Yeah, she said reopening, but I will broaden that to it going forward.
Oh, okay, great. Yeah, and I'm sorry I didn't see that in the chat. Something that I'm doing is faculty development. I'm doing faculty development pretty much constantly in terms of building capacity for people to, again, use these conferencing tools as utilities rather than add-ons or innovations.
I think this week has been about brainstorming with colleagues in our college about how to continue the education of the learners while keeping the SP safe. If we do start having in-center projects, what does that look like? Currently, we're doing some AHA programming with a glass between the learner and the assessor. So kind of think about those things as someone who works on the day-to-day operations of the center, thinking what will that look like? And also, even though we have a big center, we have lots of space, that does not necessarily mean that obviously we can fill that space. So how many people, what is safe, et cetera. So.
Yes, I think for me, it's a question, that kind of pertains to us as simulation people, that we're used to kind of in the sort of always be advocating for simulation mode. And I don't want to pull back on that. And at the same time, I don't want to accept a situation that I'm accepting as less dangerous. I want to be able to clearly say that I believe this is safe. So that's weighing on my mind, and I want to comment on Emma's comment about thinking about what is the definition of the scope of safety and how do we include patients in that calculation. So where, when, and how can the balance tip so that we can bring people into center. So far, we believe that we've been able to create safety and valuable education without bringing people into center. So anyway, we are at the end of our time. I would like to give huge thanks to Jane Miller for being with us today. Your work is so amazing and has been so enlightening for us. And please contact us with continuing questions, and this webinar will be available online later. Thanks, everyone.
Perfect. Thank you.